So very good afternoon to all of you. Before we have as we have already discussed what is retina. So retina is the multi-layered light sensitive neural tissue lining in the inner eyeball, and light is focused on the retina and then transmitted to the brain through the optic nerve. This is a basic structure. वो अभी आज की तारीख में CBSE का 12th क्लास का बच्चा भी बता सकता है. So this you should all know. The macula is the highly sensitive area in the center of the retina which is responsible for the central vision. When we talk about vision, we have got two parts in the vision. One is the central vision, another is the peripheral vision. So the macula is associated with the central vision. The macula is needed for reading, recognizing face and execution other activities that require fine and sharp vision. So the peripheral vision is responsible for any movement in the field or gross perceptions, but for your vision or for your nazar you have to bring your macula in the line of what you are seeing. So as far as the anatomy part is concerned, what is the size of the retina? So retina is a very thin layer, almost 0.56 millimeter thick, which is near optic disc, and 0.01 millimeter ora serrata. Okay, and it is thinnest is the center of the fovea. So fovea means a pit or cavity. So that is why, because it is the thinnest part, so it appears as a pit. Now what are the functions of retina? So the basic function of retina is light perceptions. So how does it occur? It absorbs photons of light. The retina converts light into the electrical impulses and sent through brain to the brain through the optic nerve, which translates the photo energy into biochemical messages and translate biochemical messages into neural messages that is interpreted in the brain. So the two important components which does this thing are the rods and cones. So these are the photoreceptors of the eye. So rods are responsible for the light and dark adaptation, and they are mostly distributed in the periphery of the retina. And cones are responsible for your central vision as well as your color perceptions. So they are concentrated more in the macular and the central areas. If we go about the microscopic or histological structure of retina, so it consists of three types of cells which are arranged in a synaptic order in the following 10 layers. So three types of cells we have already discussed. These are the photoreceptor cells, the neural cells, and the connective tissue in between. So these are the three types. How they are arranged are, so the layers from outside to inside is the first layer. Outside means if you are looking from, if I am looking towards you and I am seeing your retina, so outside means most back, and then you come from like this. So the layer which is first after the choriocapillaries is the most outermost layer. Okay, it is not from this out to that in, so it is coming from in to out. So from that outside, the first layer is the retinal pigment epithelium. Second layers are the layers of rods and cones which are projected into the pigment layers. Third is a limiting membrane, which is external limiting membrane. Then there is a outer nuclear layer, then outer plexiform layer, inner nuclear layer, inner plexiform layers, ganglion cells, layers of nerves, optic nerves, which converges onto the disc, and the inner limiting membrane. So if we look into it, when we are seeing, so actually first thing what we see from here is the inner limiting membrane, and the last thing is the RPE. But when we describe it, so the outer is the RPE and the most inner is the inner limiting membrane. So this orientation you should keep in mind. And this is a histological picture which gives you some idea that what is happening. So the pigment epithelium is on the uppermost, but you see it is just like a reverse thing. When you are seeing an eye, so this pigment epithelium is the most deepest. So this pigment and the lower one which you are seeing. So this is just a basic of the retina. Now we come to the condition which is known as retinal detachment. Detachment means when it is moved from its normal positions. So retinal detachment, it is described as the separation of neurosensory retina from its normal retinal pigment epithelium. उसको बुलाना फिर वही हो गया, बैग कैसे जाएगा. So if you remember that in the 10 layers we have talked about, the one is the pigment epithelium and rest of the all layers comes into the neurosensory layers. So when there is a separation between this, वो बैग का नहीं आ रहा यार, आगे बढ़ जाता है, बैग का एरर आएगा वहीं पे आएगा, बस आगे. So this is the structure. So the most upper one layer is the pigment epithelium. So separation from that, then rest of the layer is known as retinal detachment. So separation of neurosensory layer, rest of the all layers are neurosensory layers, and that is the pigment epithelium layer. When it is get separated from its pigment epithelium layer, that is known as retinal detachment. So basically there are three types of retinal detachment, or retinal detachment can be classified into three groups. One is the rhegmatogenous RD or primary RD, another is tractional RD, and third is the exudative RD. Rhegmatogenous RD means, rhegma means break or a hole or a cut. So RD which occurs secondary to because of a break is known as rhegmatogenous RD. Rest of the RDs are because of traction, because of exudation. So these RDs are known as secondary RDs, and primary RD is whenever somebody says he got a primary RD, that means the cause is a break. So what are the pathogenesis and signs of retinal detachment? So in rhegmatogenous detachment, the most important signs is that the patient presents, early stages the patient present with history of some floaters and flashes. Only floater is not a sign of detachment, but flashes is a sign of detachment or a beginning of detachment. So the rhegmatogenous detachment can be fresh when the patient present with a history of flashes. He says that sir, suddenly मैं देख रहा हूँ, दिख तो मुझे सही रहा है, मगर ऐसी आँख हिलाती मुझे लगता है जैसे कोई साइड में कहीं बिजली फूटी, पटाखा चला, कुछ हुआ ऐसे. It can be long standing or it can be with complication, which is like with proliferative vitreoretinopathies. Or another cause of that is with tractional RD. Most common cause of tractional RD is diabetic retinopathy leading to proliferative diabetic retinopathy leading to tractional detachment. And third is the exudative RDs. Now these are the normal anatomical landmark. When we see the central, you can see is the optic disc. This is a wide angle view of the retina. The central optic disc you are seeing, and the vessels are coming out from there. Temporal to the optic disc is the macula. Then you can see the superior inferior arteries and nerves, and this the peripheral part is the most peripheral part is the ora serrata. Ora serrata is the part where the retina ends and your ciliary body begins. So this is a picture of ora serrata where you can find that these are the normal variations you can see in the ora serrata. So you can have a meridional folds, which is a small radial fold in line with the these processes and structure are known as dentate processes. In line of that process you can have a meridional fold, or you can have a enclosed oral bay. Oral bay means like this enclosed area, which is the central area is showing the choroid and the rest of the tissue is retinal tissue is there. So it looks like as if there is a circumscribed area which can be confused from a retinal hole or a retinal break. So this is something different, which is a normal variation. If you see a small structure like here, this is a retinal hole. This can give rise to retinal detachment. This is the anatomy. Now, as you know, the eye is filled with vitreous. So vitreous is firmly attached with the retina, especially in the ora serrata. So this is a three-dimensional structure. You can see the wavy structure, ora serrata. Superior to is the ciliary body. Inferior part is the retina. So whenever there is a flashes, what the patient told, it is because that there is a pull from the vitreous which causes a traction on the retina. So the traction causes a feeling of flashes, and it causes a break, or it just tears off a part of retina, which give rise to a break in the retina, which may lead to detachments. Now, the best way to examine retina and especially RD cases are with indirect ophthalmoscopy. The direct ophthalmoscopy does not let you see the periphery of the retina. So this is a direct ophthalmoscopic. 40 minutes हो गए क्या? Now this is direct ophthalmoscopy with scleral indentation. We have a scleral depressor which is used to indent the eyeball, so that, because if it's just like if you see a inside of a ball, so you cannot see just the most anterior part of the ball. So you have to just press it. The pressing of the eyeball is known as indentation. So with indentation we can see much more area as compared to a normal indirect ophthalmoscopy. Now, whenever we see a case of detachment, you have to chart it, what is the extent of the detachment in the eye. So you have to do a indirect ophthalmoscopy and do a charting in the the red portion depicts the attached retina and the blue portion depicts the detached retina, and these are the different types how the breaks and other things are marked. Sir, gentlemen, sir, last two lines. वो आपके पास वाले दो लोग, कुछ आपके पास एडिशनल है ऐड करने के लिए? आ जाओ. हाँ, कुछ इफ़ यू हैव एडिशनल, या मैं को गलत बोल रहा हूँ तो आप आ जाओ, नहीं तो फिर. Another way of examination of fundus is slit lamp biomicroscopy. This is a specialized lens which is kept on the cornea of the eye, which let you see the fundus of the eye. So with that also you can see a fundus and detect the detachments. Now we come to something about rhegmatogenous RD. So as we told, the rhegmatogenous RD means a RD which has occurred because of a break. So there is a break through which the SRF is subretinal fluid. The subretinal fluid goes inside or seeps inside and separates the sensory retina from the RPE, which causes the separation or detachment of the retina. So usually the predisposing factor, usually you can have this in the age group of 40 to 60. Male female ratio is around 3 to 2. Myopia is more commonly associated with detachment because of its associated precursor degenerative changes. Aphakia, trauma, sometimes age-related vitreous detachment or senile PVDs, or some retinal degenerations like lattice degeneration, snail-tail degenerations, or other schisis. Schisis means thinning of the retina. So acquired thinning of the retina may give rise to breaks, and these breaks can give rise to detachments. So there is a very beautiful rule of, which is known as Linkoff rule, which tells you about, in a case of detachment, if you see a detachment, where would you expect a break to be there? So this blue part is the detached part and the red part is the attached part. Now what is the usual pathogenesis of detachment is? Usually the incidence is around 1 in 10,000 people per year. 10% of cases we find obvious breaks in this. The retinal breaks for RDs are caused by, as I told you, dynamic vitreoretinal traction. There is some changes in the vitreous which causes pull on the retina, and this causes break in the retina. So the changes are like synchisis or liquefaction of vitreous, which you see here. You can see that there is a pockets in the vitreous, which causes that there is a inertial change. If the vitreous is a jelly, it moves like one. If vitreous is jelly with liquid, so it moves in two forces or two directions. So there is a shearing force in the eye with your eye movements, and with this shearing force there is a pull in the retina, which can cause a break. So as we already discussed that what are the symptoms of rheumatogenic RD, then patient may have floaters. These floaters are because of the at the time of break there is slight amount of bleeding, so that blood spreads out in the vitreous, and patient may feel that there is a floaters in the eye, photopsia or flashes, and there can be visual defect. That means the patient can see, sir मेरे को यहाँ से यहाँ तक का नहीं दिख रहा है, सामने तो दिखता है, सामने दिखता है मतलब macula is still not detached, but side of the portion is not seen. और sometimes patient के साथ मुझे लगता है कि कोई पर्दा सा गिर रहा है. So if patient symptoms are like this, that means the patient is having detachments. And central vision loss is there if the detachment extends till the macula. If the central vision is already lost, then the patient don't see anything. His vision will be just like finger counting or less than that. So what could be the NTA segment signs or signs from outside? So you can have a sluggishly reacting or Marcus gun pupil in the affected eyes. There will be initial increase of IOP, but that is very transient. Most of the time when the patient comes with in the OPD, after the detachment the IOP is low. IOP intraocular pressure is lower than the normal, because there is the normal mechanism of aqueous secretion is disturbed, so the eye is in the softer form. An NTA segment may have mild amount of uveitis, or if there is a long-standing detachment, then you can have a signs of chronic uveitis like posterior synechias, pigments, and other changes are there. What are the signs of long-standing RDs? That the IOP will be increased, the retina will become totally opaque or semi-transparent. There would be like tobacco dustings in the vitreous and just behind the lenses. There will be thinning of the retina in the periphery or in the centers. There could be a secondary changes in the retina in the form of cysts or neovascularization, or there will be membranes over the retina. These all are the signs of chronicity, which is known as vitreoretinal proliferations, which is one of the cause of failed RD surgeries, because if there is chronicity, this PVR does not let the retina to go back in its normal positions. And if you do a ERG or electroretinogram, then electroretinogram is totally flat in a case of total RD. If it is total RD, then it will flat. If it is partial RD, then you can have some recording on ERGs. So that was the rheumatogenic RD. Now the second is the exudative RD. As the name suggests, there needs to be some exudation, plus there should not be any break. If there is no break, then only exudative RD can be diagnosed. If there is break, primarily it is taken as to be a rheumatogenic RD with some sort of exudations. So the exudative RD, the causes of exudative RD, most common cause of exudative RD is choroidal tumors, which could be primary or metastatic, intraocular inflammations, or systemic conditions like toxemia of pregnancy or hypoproteinemias. It could be iatrogenic like post-RD surgeries, or in cases of laser, excessive laser photocoagulation may give rise to exudation from the choroids, which can give rise to exudative RDs. And the other causes are choroidal neovascularizations or uveal effusion syndrome. So these are the causes of exudative RD. Main point is that if you don't see a break in the eye and the retina is detached with bully form of things, then it is an exudative RD. Another thing in exudative RD is that exudative RD shifts with the position of the patient. So this is a sign of shifting fluid. If the patient is sitting, the lower retina will look more detached. If the patient is lying, the upper retina will look more detached. So the shifting of the fluid is a sign of exudative RD, which will not be present in case of rheumatogenic RD. So this you can see that there is a choroidal tumors on the upper part, and inferiorly there is a detached retina because of the exudations. So there is retinal and choroidal abnormalities which breaks down the blood retinal barriers, and their fluid seeps into the subretinal space, and then it causes an exudative RD. And this type of picture may change if the position of the eye is changed. The patient, if this is in the supine position, when the patient is sitting or standing, then the inferior part looks detached. If the patient is lying, then the posterior pole or the superior part may become detached. The third type is the tractional RD. Traction means something is pulling. So when something is pulling, it is causing the detachment of the retina. Again, the patient may present with floaters and photopsia, but it is usually 99% of cases it is absent, because tractional RD is a chronic disorder. It cannot occur acutely. Rheumatogenic RD can occur acutely. Patient अच्छे से सोया था और सुबह उठ के उसको RD हो सकता है, but tractional RD cannot occur like this. Okay. So what are the signs which give rise that in the retina you will not find a break? Because if break is there, it is a rheumatogenic. The configuration is usually concave. That means in rheumatogenic RD we are talking about bully. That means the retina is elevated. But in traction RD something is pulling. So the retina will look like a concavity. So that is a sign of something is pulling from up. The mobility of retina will be severely reduced because there is fibrosis. There you can have a pseudo hole appearance which can be at the macula or in the periphery. There can be subretinal demarcation lines because of the proliferations, and vitreous, there could be a PVD present, or there can be hemorrhages or sometimes some proliferations which is growing into the vitreous. You can see this picture and you can see that there is a crescent shape of yellowish thing which is a proliferation which is occurring on the retina and causing a puckering of the retina at the inferiorly. So this is tractional retinal detachment. Most common cause of tractional detachment is diabetic retinopathies. Something about the management. Mostly we are talking about the rheumatogenic management, because other causes are, first is the treatment of the cause and then other things. Rheumatogenic RD surgery as such is, if somebody say RD surgery, that means the surgery is for rheumatoid detachment.